Thank you for the opportunity to speak. I get the pragmatic part of the deal, and those who know me know that I am all about pragmatic clinical practice. So I am the site chief at a busy hospital in Washington, D.C. I am in the OR every day. I am also the chief quality officer and therefore chief cat herder for U.S. Anesthesia Partners, which is a nationwide physician-owned private practice. I have worked for the ASA. I was their chief quality officer for a bit, and I talked to everybody in the business. So what's our landscape now? Just starting out, we have a very strong recommendation that you have now heard for quantitative monitoring of every patient who gets neuromuscular blockade. How many people are doing that in the real world? Well, let's ask. How many of you are doing this routinely every case that gets paralytics? A few. And you're all in some shiny academic building? Virginia Mason in some cases, yes, correct, okay. But out there in the real world, not so much. And why? Why is this? We don't recognize the problem. Most of the consequences of residual blockade occur after we drop the patient in the recovery room, so we don't see them. They are hard to measure. It's a lot of small harms instead of one big harm, so it's hard to count those things. And the technology has been historically clunky and hard to use. You heard some reference to that. And then there's the whole Sugamidex thing, which you just heard some discussion about, right? We are fortunately winning the Sugamidex battle, I'm happy to say, after a decade of working on this. How many of you have unfettered access to Sugamidex? You can give it to any patient you want. I'm happy to say my University of Maryland hospital is now that way. It's in the drawer. We can take it out and give it to anybody. And I would say nationwide private practice, it's about 50-50. Places that are like that versus places where there's still some sort of barrier. At Baylor, where I just came from in Dallas a year ago, you had to go to the pharmacy window in the OR and promise your firstborn child to get the Sugamidex. She has a lot of college debt, so I was always happy to do that. Part of the issue is, as I said, understanding the problem, recognizing the consequences. In fact, what the scientific evidence shows is that residual blockade is bad, and it's common. If you are simply using qualitative assessment, many of your patients hit the PACU still measurably weak, and they have a higher risk for a whole number of different pulmonary complications that add to length of stay, add to complexity. There's a nice paper out there from MPOG, the Coalition of Academic Groups, looking at the relative cost benefit of adequate reversal or preventing residual paralysis, and it discovered that these complications do add up. If you just look at the length of stay difference in patients who have pulmonary complications, you can very quickly buy all the Sugamidex and all the quantitative monitoring that you desire. Unfortunately, our hospitals in America are not constructed to think that kind of big picture way. You're talking about different silos, an OR capital budget, a pharmacy budget, right, and then the eventual patient outcome that the hospital may or may not be able to measure or grasp. Most of us have seen accelerometers, so for all you not using these routinely, how many of you have seen an accelerometer, a quantitative neuromuscular blockade monitor as part of your residency training or wherever? Yeah, mostly. Even me, 30 years ago, we had them. We could, there was one or two hanging around the OR, and people were doing research with it. They are mostly perceived, as I said, as being clunky. They require calibration. They require free movement of the thumbs. The arm has to be out somewhere where you can get it. They're finicky. However, I will tell you, if you haven't seen some of the new technology, get over to the huckster's room while you're here this weekend and take a look, because it's gotten a lot simpler. Last time I looked at a bunch at Baylor, it was pretty simple. You slap it on, you turn the box on, you get a number from 0 to 100. This is really pretty convenient. And you can get now hybrid models that include both accelerometry, which is relatively free once you buy the box, as well as the EMG ones, which require a special pad, but that's $20 a case. Again, compared to the cost of Sugamidex, if you're preventing one dose of Sugamidex in 5 patients, which is probably about right, patients who don't need reversal, you've already paid for the device. There are some other detail on the slide. It only takes a few seconds longer to actually use quantitative monitoring. It does allow real-time titration of the block when you do that big case with quantitative monitoring, and can watch that number change and dose your relaxant accordingly throughout the case. You get a lot smarter, you end up using a lot less relaxant over the course of the case, and obviously you get a much more confident reversal and extubation at the end if you're over 90. So as you talk to your hospital about it, and here's the pragmatic part, right? So how do we sell it? How do we get from nobody in the real world using this to everybody using it like we should? You know, this is trench warfare, building by building. You need to have the value proposition in your head. We are preventing these complications. Yes, it's going to cost more, both in a little bit of technical cost and in the much larger change management cost. As somebody very smart said recently, and I wrote it down, everybody likes progress, nobody likes change. And that is exactly the rock that we are rolling up the hill right now with what is clearly evidence-based best practice, is we need to change. We need to understand the cost. So now we're getting into tactics here. You need to figure out how you're using Sugammadex today. You need to find the person who's paying for that, and you need to pitch them. And say, look, if we had this monitoring, we'd give less Sugammadex. We'll save some money. Your pharmacy will appreciate that. You need to get them to share that appreciation with your OR capital equipment committee so you can get the stuff. All right? We need to be willing to do our part to write appropriate protocols. It says we will use Sugammadex responsibly in people who need it. We won't give it to people who don't need it. Right? We will use these monitors on these kind of cases in this way according to our internal guidelines, and you have to be able to step up and create those to improve patient care. Here are some one-liners that help. These are the evidence-based recommendations of our professional society. It is clearly better care. And I am not afraid of using the mother argument. Like, if your mother were having anesthesia here, wouldn't you want her to have the best possible care? Okay, that sometimes works on hospital administrators. We are following the lead of large and reputable academic institutions, many of whom are doing this routinely now, as you saw from the show of hands. It will help us use Sugammadex less and more responsibly, the right dose at the right time. And, you know, bottom line, all the cool kids are doing this. If you want to scare your hospital's lawyers, you can tell them that if you have a complication related to residual blockade, for instance, a patient who needs reintubation in the PACU where it goes poorly, and that becomes a lawsuit, you are not going to have a leg to stand on. You're going to be writing a big check, right? That should not weigh economically. That is not an evidence-based statement, but it's a pretty damn good anecdote, and it will help with your hospital administrators. All right, internally in your group, you need to educate everybody on everything I just said, why this is important. You need to find a local champion. Maybe it's you, maybe it's one of your colleagues, who will do the legwork of bringing the vendors in, getting the demos, and incidentally, all of the companies are perfectly willing to come to your hospital with a box and a bunch of disposables, put it on a bunch of patients, stand there next to the monitor, and teach everybody how to use it. And this is something, when you hit the Huckster's room, collect the business cards, give them a call, get them to come in, buy you lunch, if you're in private practice, sorry, and get your demos. And hands-on is the best way to teach anybody anything, and it really works well in this area. Your hospital administrators, you have the data, you have the evidence, you have the ASA guideline, and you can make a well-reasoned economic argument for doing this. Like, collectively, we will save money, our patients will have fewer complications, they'll go home quicker, they'll be more satisfied. And then you just got to work the problem. So with that, I will quit. Thank you all very much for your attention.